medical comorbidities in autism spectrum disorders. Next slide, please. Because this is approved for continuing medical education, I do need to acknowledge these disclosures of relationships I have with commercial interests. Next slide, please. And then I will be discussing some off-label use of both over-the-counter and prescription medications for the treatment of some problems in autism, and I need to disclose that. Next slide, please. So our objectives for today's presentation are to identify some of the medical conditions that commonly occur in individuals with autism spectrum disorders, outline a plan for addressing some of these conditions as part of the overall management plan for someone with autism, and identify some sources for evidence-based management of the medical comorbidities that we see in autism disorders. I think that last one is important because there's been a lot of questions about that and really about this whole topic today. Next slide, please. So the issue of comorbid conditions in autism spectrum disorders has been discussed for the last couple of decades. There have been reports that several medical conditions seem to occur with a high incidence in people with autism. The conditions that are most commonly described are GI issues, sleep disorders, epilepsy and seizure disorders, and immunologic problems. And part of the theme for today's presentation is that medical conditions can have a significant impact on the overall treatment of a person with autism spectrum disorder, and it's important to be aware of any medical conditions that are present and to address them appropriately. Next slide, please. Now, there's been a lot of controversy about these medical conditions as to whether these really occur more frequently than in the general population or simply about the same. In addition, some people have wondered, are these medical problems, when they appear, are they part of the child's autism spectrum disorder, or is it simply an additional problem, the same as any of us on this webinar might have both diabetes and high blood pressure? So are the two related, or are they simply occurring and have no real relationship? And that's been an important point to consider. And then finally, if we treat these medical problems appropriately, can we improve the core autism symptoms in areas of behavior, communication, and perhaps even developmental progress? Next slide, please. So let's start off by talking about GI conditions. In our surveys with families through the Autism Treatment Network and the Autism Intervention Research Network on Physical Health, or AARC, we found that GI conditions were one of the top priorities of these families. And in the medical literature, the incidence ranges from about 17% to as high as 85% in some surveys of people with autism having GI problems. Most commonly reported GI conditions are constipation, diarrhea, and abdominal pain, but really the full range of GI disorders have been reported, including gastroesophageal reflux, ulcerative colitis, and inflammatory bowel disease. So pretty much any GI problem has been described in people with autism. Next slide. There's also been some confusion and controversy over the last 15 years or so. Some original reports that came out of England describing a so-called autistic enterocolitis, that there was perhaps a unique type of GI problem occurring in people with autism. And there was some difficulty in other medical centers duplicating the findings that had been reported, but the fact that there might be some unique autistic enterocolitis led to a lot of primary care doctors being hesitant to treat the GI symptoms because they thought perhaps there's something more unique here and I shouldn't be trying to deal with it as I usually would. In addition, because of sensory issues and other factors associated with autism, many patients have special diets because of their food sensitivities or their selective diets, and families come to their primary care doctor asking about these diets and should we be on them. And most primary care clinicians can't keep up with all of the various diets that have been recommended for people with autism. So these problems led to a lot of primary care doctors not addressing their patients' GI symptoms. It also led to parents reporting that their primary care doctors didn't seem to want to listen to their concerns or treat these symptoms, and to add further problems, they wouldn't refer them to specialists for consultation. So parents were very frustrated, primary care clinicians are frustrated, and a lot of this has to do with identifying what is really going on here, what is the underlying truth, as opposed to what are the statements that are being thrown about that don't have much evidence to support them. So let's discuss this a little further. Next slide, please. So if we look at the medical literature, and we're going to have a sampling of some studies here, are there really more GI problems? Well, in this study by Smith and Farnworth and company just a few years ago, they examined bowel symptoms in children with autism, and they compared this to normal children, typically developing children, and also children with other developmental and neurological disorders. And in their survey, they found, yes, children with autism have more bowel symptoms than typically developing children, but they found also that they don't have more than what's seen in children with other developmental and neurological disorders. That's an interesting point because it makes you wonder, is there some connection between GI problems and developmental problems broadly, if not autism specifically? Next slide, please. In another survey that came out of the Mayo Clinic a few years ago, they did a review of several thousand patients who'd been through their clinic over the last couple of decades. And based on their information, they didn't believe that there were more GI problems. They did find that constipation occurred much more often than in typically developing children, about 33.9% versus a little over 17%, so almost twice as often. They also found a lot more food selectivity, as noted here. But the authors felt that these differences were due to behaviors related to autism, and they did not feel that these represented a true underlying GI problem. Next slide, please. Another study out of Cincinnati, one of our ATN AARC sites, looked at the prevalence of chronic GI symptoms in children with autism. And in their sample of 137 children, almost a fourth of them had GI symptoms. Most commonly, they found diarrhea in about 17% of these kids. Now, this was just looking at the children with autism coming to their center, so there was no comparison group. So is this more than the general population or not? We really can't say, but we can say that GI symptoms at least seem to be occurring fairly frequently. Next slide. More recently, just in the last couple of years, a study out of 4 hospitals in Boston looked at not only at GI problems, but other medical comorbidities that occur in children and young adults with autism spectrum disorders. They examined health records of over 14,000 individuals at 4 Boston hospitals, and they found increased rates of inflammatory bowel disease, non-inflammatory bowel disease GI conditions, and also other medical disorders. This is one of the newer and more carefully designed studies and seems to indicate that there truly are more GI problems. And we'll come back to this a little later on in today's presentation. Next slide, please. And then another publication very recently by Bresnahan and company looked at the association of maternal report of infant and toddler GI symptoms with autism to see, are there more GI problems in these people. This is an interesting study because it came from registry data out of Norway. Children and their mothers were identified at the child's birth and followed for several years. And the mothers completed questionnaires regarding their child's health for several years during this study. As time went on and the children grew up, some of those children were identified with autism. And for this study, they went and looked back at the first year symptoms of these children, comparing them to those children who did not develop a diagnosis of autism. Now, this was not a pre-selected population. These were all the children who were born in Norway. And what they found was in that first year of life, before the parents had any concerns about a developmental problem or autism, these families were reporting more GI symptoms with more difficulties feeding, children having more problems with constipation or diarrhea and other symptoms. So we are seeming to see that there is truly more of a GI problem in people with autism. Next slide. So, are there more GI problems? Well, who really knows? It's hard to say. If you'll click again, please. Several studies have been done. They've had somewhat conflicting results, and the most recent studies seem to favor an increased incidence for these disorders in people with autism. Click again, please. So there is a little inconsistency and controversy here, but is there anything that we can agree on regarding this issue of GI problems? Next slide, please. Well, I think there is some common ground, and a publication came out, a consensus report, which included many members of several of our ATN AARC sites a few years ago in Pediatrics, a medical journal. One article looking at the evaluation, diagnosis, and treatment of GI disorders in these individuals, and the second companion article, recommendations for evaluating and treating these problems in children with autism spectrum disorders. Next slide, please. And what these two articles presented was the fact that children with autism who have GI disorders may be presenting with behavioral manifestations. Remember that many people with autism have difficulties communicating, many of them are nonverbal, and some of their unusual behaviors may in fact be ways of them communicating that they are having GI problems, but it may not be as obvious to the family or to health professionals. Certainly we need to be aware of that. We need to be in tune with the possibility that there's a medical problem at present when children are presenting with behavioral manifestations, and not only children but adults. And then the group felt that children with autism can benefit from following general guidelines for the diagnostic evaluation of abdominal pain or chronic constipation or gastroesophageal reflux disease. So in other words, the recommendation of this group was if a child with autism has GI symptoms, they should be evaluated the same as you would any other child who had those GI symptoms. Next slide, please. So if a child with autism has recurrent problems with constipation, it makes good sense to treat this the same as you would in a child who doesn't have autism. And the same is true if they have diarrhea or GE reflux or other symptoms. So I've presented to you how we got into this situation of primary care providers feeling uncomfortable and hesitant about addressing this because of all of the information that was being presented that was of questionable value. And as we get more evidence, we start seeing a better picture of this, which leads to better treatments for this. And so, in fact, our current recommendations are to work these children up. And we're seeing this across the country where primary care doctors and GI doctors are more willing to evaluate these children than they would have, say, 10 years ago. Next slide, please. Now, part of the work that we have done with the ATN and AARC has been to try to develop evidence-based guidelines for managing comorbidities in children with autism. And here we see the algorithm for the treatment of constipation in children. It's not terribly clear to you. It's a large algorithm and a lot to squeeze onto a slide. My message here is that there is evidence for management of GI problems that can be effective, and quite often this is the same as what we see in typically developing children. There are some children who have very perplexing and difficult to manage GI problems, but the great majority of children with autism who do have GI problems will respond to our standard treatments for those problems. And this algorithm for constipation is just one example of what we've tried to do to help reassure healthcare providers how to manage these problems. Next slide, please. Generally, good clinical practice dictates that people behave better and perform their best when they feel well. I certainly do better when I get a good night's sleep, and if I'm not sick with a cold or some other illness. And I think most of us on this webinar feel the same way. In addition, people generally will perform below their abilities when they are ill and don't feel well. So it makes good sense that if we treat the medical problems that individuals with autism have, this could have some benefits on other aspects of their autism, such as their mood or their behavior, and as a result make them more available for learning, whether this is through their behavioral interventions, school interventions, and so forth. Next slide, please. So let's move from GI problems and move on to sleep problems and discuss those. This is another very common concern. Next to GI problems, GI and sleep are the two most common concerns of families attending our ATN AARC sites. And it's been reported in 50% to 80% of children with autism in a variety of studies. And we've seen it in over 50% who come to our ATN sites. The most common concerns that the families have are sleep onset, or getting their child to fall asleep, and then sleep maintenance. Their children are awakening after being asleep for a few hours, and then there's significant difficulty getting their child to fall back asleep. Perhaps even the child stays up for the rest of the night. Other concerns that we see, again, run pretty much the full gamut of sleep problems. Parents reporting irregular sleep-wake patterns, problems with their child being early risers, problems with poor sleep routines and very unpredictable sleep, and so forth. Next slide, please. What we do know from other studies of sleep problems in typically developing people, sleep problems lead to daytime behavior problems. Compared to children with autism who have no sleep problems, children with autism and sleep problems have more internalizing behavior problems. Those are problems with withdrawal or anxious behaviors or depressed symptoms. They also have more externalizing behavior problems, such as overactivity or aggression or inattentiveness and impulsiveness. And they also have poorer adaptive skill development. So when we take children that we see in the ATN and AARC, all of whom have autism, If we compare those who have sleep problems to those without sleep problems, we find that the ones with sleep problems have numerous other problems associated with that, with their behavior. And then among all of those who have sleep problems, the more severe the sleep problems, the more severe those behavior problems. And the reference here was a study done with data from our network a few years ago. So dealing with sleep problems is an important part of managing people with autism, identifying that a problem is there, and then doing our best to address that problem. What they've seen in typically developing people, there are times when some sleep problems, when they are managed, daytime behavior problems can nearly resolve. So this is an area that we're very interested in and hopeful that we can improve life for our families if we can deal with their sleep problems better. Next slide, please. So again, specialists within the ATN AARC have developed a practice pathway for managing insomnia in children who have autism spectrum disorders. It's, again, a little small and difficult to read here. If you go to the reference, you can read the full article as well as the review this algorithm. But there are good evidence-based treatments for managing insomnia in children with autism. Next slide, please. A little close-up here, and we're going to talk more on the next slides, shows that the first question is we need to ask if there is a sleep problem. Across the United States, across all children with or without autism, it's been found that the majority of healthcare providers are not asking about sleep problems. And I've already presented to you how sleep problems can have a significant impact on our daytime behavior and functioning. So our first step is to screen for insomnia. Is it present or not? And as we move across at the top line to the right, if there is insomnia symptoms present, the next step is to look for possible medical contributors that might be affecting that. And then as we move further to the right, then we're going to determine if the family is able to follow an educational approach in managing these sleep problems. If we find medical contributors, as we move down that center column, then we need to evaluate for those medical contributors and perhaps consult with specialists on this. Let's go on to the next slide. So, what kind of medical conditions might be contributing to insomnia or sleep problems? Well, GI conditions can do this. Does the child have a history of reflux or any symptoms of reflux? A common problem with people who have GI reflux is that when they lie down, their stomach contents come up into their esophagus, causing heartburn and discomfort, and sometimes even spitting up stomach content. So when we hear that these children are having difficulty falling asleep, it could be because they have reflux as a contributor to their sleep problems. Also, if they have constipation and have some abdominal pain because they have not had a bowel movement, these are some other conditions to consider. Seizures are another area for us to explore because seizures occur more frequently in people with autism, as we'll discuss in a few minutes. And then symptoms of a sleep problem such as sleep apnea. So does the child have snoring or breathe loudly, or are there periods where the child seems to stop breathing? Next slide, please. We also ask about any other problems that might be causing this child to be uncomfortable. So is there problems such as a toothache or a tooth abscess? Are there skin conditions like eczema where they are itching and it's difficult for them to lie still and fall asleep? Could they be hungry because of selective diets and difficulty getting adequate nutrition and feeling a sense of fullness? And then on examination, do we have other factors like large tonsils which are blocking the airway and making it difficult to breathe? Are there nasal congestion or allergies or other issues? So part of the evaluation of sleep problems is taking a good history and performing a good physical examination to look for other medical conditions that might be contributing to or even be the major cause of the sleep problem. Next slide, please. Now, I mentioned that some of these children might have hunger pains because they haven't had an adequate diet during the day or adequate food intake. Separate from that, it's been shown in typically developing people that iron deficiency without anemia is associated with something called periodic limb movement disorder and with restless sleep. What we have found with our work across the ATN AARC is that this is fairly common in children and adolescents with autism. And in one study, it was found that this occurred in almost half of people with autism compared to roughly 10% of typically developing control group. So there is that association between sleep and nutrition. And given my previous comments about GI problems and sleep having a relationship, we're starting to see that multiple factors are interacting to contribute to the overall problems with sleep, abdominal pain, appetite, and behavior that we might see in any individual with autism. Next slide, please. Well, if we see these sleep problems, what do we do for them? When we conceive of autism spectrum disorders as a neurodevelopmental disorder, and from what we know through other research that have shown differences in the structure of brains of people with autism, it's easy for us to think that these people are having problems sleeping because their brains are developing differently, that perhaps they're wired differently, neurotransmitters might be working differently than they do in typically developing people. And if we follow that line of thinking, it's very easy to think that these children are going to require medication to manage their sleep problems. What we have seen with some of our work across the ATN AARC is that non-pharmacologic methods work more than 70% of the time. What we've also found is that families require a lot of support in using these methods. Many parents report problems with getting their toddlers to fall asleep, and using behavioral methods and what is called good sleep hygiene, a good bedtime routine that is designed to help people wind down, relax, and fall asleep. Those methods work in people with autism also, but part of the difference is that the families seem to be very worn out at the end of the day because their child has had a lot more behavioral issues during the day than other typically developing kids who may have just a sleep problem. So we have found that the families require a lot of support, but if we're able to give them that support, give them that education about what they should be doing, we have been successful over 70% of the time. That still leaves a fair number of families and children where we're not going to be successful, and we do have to sometimes turn to some medications. There is good scientific evidence out there that melatonin can be helpful in these cases. Several studies that have shown that it is better than a placebo in helping promote drowsiness and onset of sleep. And the typical dose that is used in these studies ranges from about 1 milligram to 3 milligrams of melatonin given in the hour before going to bed. Melatonin is available over the counter. It has a very safe profile and has been used both in people with autism and without autism. If we have to go to prescription medications and melatonin has failed, there's also good evidence that a medication called clonidine can be helpful, and that is one that is commonly used by clinicians across the ATN and AARC. The medications that many of us see advertised on TV to promote sleep, the FDA-approved hypnotic medications as they're described, are not recommended in the child and adolescent age group and not recommended in people with autism. There is a tendency for them to cause some dissociative feelings that many children and adolescents find uncomfortable, and so they can actually be counterproductive in terms of promoting sleep. Next slide, please. Let's move on to epilepsy. I mentioned earlier there is a high rate of epilepsy reported in people with autism spectrum disorders, and various studies report a prevalence from 5% to as high as 46%. Most studies feel that this is in the range of about 15 to 20%. And in a survey of our families enrolled in the ATN registry, we found that 19% reported having epilepsy, fairly consistent with other published reports here. Epilepsy in children with autism typically will present in the first 5 or 6 years of life. That's when it's most commonly presenting, and then during the elementary school years we tend not to identify epilepsy. It is not appearing. It's already appeared or it doesn't. But then there's a second peak during adolescence when people with autism are at risk of developing epilepsy again. So it presents either early in life or during adolescence. The most common types of epilepsies that are seen are what are called partial epilepsies that are focused around the central or frontal temporal regions. Over the years, many people have looked at EEGs as potential ways of identifying or diagnosing autism, or trying to correlate this with some of the neurologic or developmental findings that are seen in people with autism. And none of those studies have been successful, unfortunately. One of the findings that has been seen are what are called interictal epileptiform discharges. This does not meet the criteria to be considered epilepsy or a seizure disorder. They occur in people who don't have autism. They occur more commonly in people with autism, but it's not clear just what significance these are. Some studies have reported anecdotally trying to treat these with anticonvulsant medications as though they were seizures, and some people feel that it is helpful, but at this time there's no good evidence that treating that is of any help. In addition, at this time, EEG studies are not routinely indicated unless there's some clinical suspicion that there is a possible seizure disorder present. If the family is reporting that the child has episodes of frequently falling down or losing consciousness or having staring spells or other unusual involuntary movements. But we don't routinely get EEG studies on individuals with autism unless there's something clinically suspicious. Next slide, please. We have seen some risk factors associated with epilepsy and autism. Some studies have reported that it seems to be more common in those who are of lower cognitive functioning or lower IQ. It seems to be related to people with sleep problems. On physical examination, those patients who have epilepsy have a tendency to have problems with muscle tone or hypotonia or coordination problems. Some studies have shown a relationship with an increased number of repetitive behaviors or unusual sensory interests. And one of the concerns that many neurologists who deal with a lot of children with autism have had concerns about is being more suspicious of spells, as parents describe them. And parents will say, you know, there are times when my child just seems to stare, and not do anything, or just sort of freeze and doesn't move for several seconds and then starts moving again, and there seems to be some transient cognitive impairment. And that can be suspicious of what are called petit mal epilepsy seizures, and so further study of that would be recommended. But also people who have very restless sleep, there's a new concern that perhaps we are missing some sleep epilepsy disorders in children who have very restless sleep, can't seem to stay under their covers, fall out of their bed frequently at night, and so forth. And I think that's an area that a lot of clinicians overlook and are not as suspicious, and perhaps should be considering getting an EEG and examining that a little more closely. Next slide, please. The next area is in the area of autoimmune conditions, and this is another one that is not well studied, somewhat controversial, and a lot more work needs to be done here. Some studies have shown that there's an increased rate of autoimmune conditions in first and second degree family members of individuals with autism. Autoimmune conditions include problems such as rheumatoid arthritis, Hashimoto's thyroiditis, and so forth. Some of those studies that have found an increased rate have found that it is greatest in the mother of the child with autism. And as noted here, again, Hashimoto's, rheumatoid arthritis, multiple sclerosis are among the most frequently reported autoimmune conditions that are seen. These all make us wonder, is there some autoimmune condition, especially when we see this relationship with mothers, that is causing an impact on the developing fetus that might be setting the stage for this child to develop autism. But that's not the point of today's discussion, but it's another area that is being investigated by researchers. Regarding the autoimmune conditions, the study I mentioned earlier out of Boston that had 14,000 individuals across 4 hospitals, they did find some autoimmune conditions were appearing with an increased rate, in particular inflammatory bowel disease and diabetes mellitus. So it's not clear what's going on with autoimmune. I think this is an area of further study in autism as we learn more and more about autism and the medical conditions associated. Next slide, please. So that study that I mentioned by Kohani and colleagues, this is a fascinating bar graph showing the prevalence of comorbidities of autism and the prevalence of autism in these comorbidities. So in this slide, the dark gray bars show the prevalence of a disorder in people with autism. So starting at the far left, autoimmune disorders in the dark gray, the presence of autoimmune disorders in people with autism was about the same as the light gray, which is the prevalence of autism in people with autoimmune disorders. So let's go to the next column, looking at bowel disorders. The prevalence of bowel disorders in people with autism in this study approached 12%, whereas the prevalence of autism in people with bowel disorders was about 1.6%. Now that's about what the current rate of the CDC prevalence rate is, about 1 in 64, or about 1.5 or 1.6%. The next column also, we see in children with central nervous system anomalies, a little over 12% of people with autism have these problems. If we look the other way around at people who have CNS anomalies, about 6% have autism. That's an increased rate also over what we would expect in the general population, but we also are talking about the nervous system, so this makes sense here. Moving further down to the middle of the slide, we see also that there is that increased incidence of epilepsy in people with autism. And then the next column, FRX, or Fragile X syndrome, this is a very important column, I think, because it shows that about 0.5% of people who have that diagnosis are the people who have autism. And we've known that there's a relationship with Fragile X and autism, but by no means are the majority of people with autism also have Fragile X. But we look at that gray column, and the proportion of people with Fragile X who have autism is about 21%. So autism occurs very commonly with Fragile X, but it doesn't explain why we're seeing so much autism, because Fragile X is only less than 1% of all people with autism. So this study and the data presented here, I think, is very important for us to look at and see that there are some comorbidities that are occurring far more frequently in autism. Next slide. This slide also looks at this, not comparing to those diseases as the slide before was, but instead, how often are these comorbidities occurring in autism versus how often are they occurring in the general hospital population. And once again, we see an increased rate of bowel disorders, epilepsy, and over to the far right, sleep disorders also. So we're getting some nice population-based data that suggests that these problems are very real and that we need to be aware of them, and we need to find ways to better identify them and manage them. Next slide, please. Now, I'm a pediatrician, and throughout my presentation, you've heard me refer to patients with autism primarily as children or adolescents. One of the things I think that we tend to overlook is the fact that as our children and adolescents mature into adults, any medical problems they have often continue with them. If they had GI problems or seizures or ADHD or aggression problems when they were 12 or 17 or at 20, they're going to probably continue with them. So as we work on transitioning them to adult care, we need to try to plan for an adult subspecialist who can advise the patient's adult primary care physician on how to manage these. And another important thing we tend to overlook as we move to adult care is making certain that each adult subspecialist is going to be able to take the patient's insurance. We have less of a problem with that with children, but it is still a problem with adults, with physicians who don't always treat everybody according to their insurance plan. Next slide, please. Patients who have seizures, I mentioned earlier that we see a peak of onset of seizures during early childhood and then again during adolescence. Adolescents with autism are more likely to have new onset seizures than at any time since before they entered school, and they aren't going to have as high a risk after they've completed puberty. On the other hand, an adult with autism who develops seizures, that's as uncommon as it is in typically developing people. So when we see that, we need to investigate that right away. This is a concern and not something simply to dismiss because we see increased risk in people with autism. Depending on how it presents, it can be quite a concern. Next slide, please. In addition, adolescents with autism who have tic disorders, during puberty, they're more likely to have an increase with those tics, but after completing puberty, the tics seem to stabilize. They continue to worsen only in a small percent of individuals, and most of the time they get better. So this is helpful information to families who are wondering what's going to happen in the long run for their now adult child. Next slide, please. Catatonia is a neurologic problem that presents behaviorally with rigidity, holding their body in the same position or having extreme slowing of movements and difficulty moving. It is something that we see in autism more frequently than in typically developing people. And if it's going to happen, it's most likely going to occur about the time that we enter puberty. And I've had several patients who, during their adolescent years, started developing problems with this. This also can continue as they become adults, and if we are dealing with adults, their primary care doctor needs to be able to investigate this, be aware of it, and identify subspecialists, adult providers. Usually these are going to be neurologists or psychiatrists who are comfortable with managing and evaluating these problems. Next slide, please. And then of all the health issues seen through the lifespan of individuals with autism, two that we have not addressed today, I've focused on medical conditions more than on behavioral health conditions, but anxiety and depression are ones that seem to worsen with time rather than remaining the same. And an area of interest now is in managing this with adults, and concerns that there are many adults with autism who may be depressed and require more appropriate care, either through therapy with a therapist or perhaps even medication. So we need to be tuned into that as we transition these young adolescents and young adults to adult care providers. Next slide, please. So my point here in summarizing is that as our patients mature, we need to start thinking about planning their transition to adult care providers. And this doesn't start when they're suddenly 18, but in fact we need to start preparing the family and the patient for this earlier. And most transition experts feel that this ought to start at about the age of 14. This is something we're going to be working on across the ATN and ARP, is developing some nice standardized bundles for approaching this and getting this transition going. We need to help advise families about preparing their child for independent living, making plans for secondary education or employment, and becoming more aware of the resources that are going to be available for them and how to access them. That is a big concern because those services vary from state to state. So every family needs to be aware of them, but the generic information to provide them isn't as helpful as the specific information state to state as to what is going to be available and how they're going to qualify for them. Next slide, please. When we look at that medical care for adults with autism, they need routine annual preventive and health maintenance visits the same as those of us on this webinar do. They need to see a dentist and a primary care provider who follow regular preventive and health maintenance, age-related guidelines, and recognize the fact that people with autism is not protective against developing the same kinds of illnesses that those of us on this webinar might develop: cancer, pregnancy, cardiovascular disease, and so forth. And some conditions, as we've discussed today, are more likely to occur, and they need to be tuned into that. Problems such as epilepsy, GI problems, and sleep problems. So when we deal with the medical comorbidities that occur with autism, as these children are growing up, we need to be aware of them, identify them, manage them, and as they mature to adulthood and we transition them over to adult providers, we need to see that they are moving on to providers who are aware and comfortable with managing all of these conditions. Next slide. That's all I have planned for our presentation today. We've got several minutes left, and I'd be happy to answer any questions folks might have.
So if anybody has a question for Dr. Coury, they can either type it into the questions bar and I'll read it aloud, or you can raise your hand and I will unmute you so that you can ask your question aloud. Does anyone have any questions?
So I've mentioned some of the stuff that we're doing across the network, and over the last few years we have worked to screen and identify problems such as insomnia or constipation for all the reasons that I pointed out today, because these are common, because they have a significant impact on the quality of life, and because they are treatable. If we treat them appropriately, we feel we can improve the quality of life and perhaps have a good impact on their autism-related symptoms. Going forward across the network, we're looking at developing better bundles for screening for these concerns. What else should we be bundling with sleep and GI problems? How can we reliably, predictably screen for this at every visit so that we don't overlook it, so that we do identify it when it's there and we are able to work on it and address it and make it better? And then the next step, as I mentioned, is that we want to bring transition into this bundle of activities that we do with a high degree of reliability so that it isn't overlooked. I was discussing transition with a parent of a young adult a couple of years ago. This was a family that had access to excellent medical care, not in my community, but elsewhere in the United States. And when I was discussing transition with them, the father said, "Our doctor never brought that up." I commented that I do that routinely with my patients, but as I reflect on my own practice, I couldn't say that I do it with 100%. I feel like I do because I know I should, and I know that I do it with a good proportion, but it's all about developing methods that we will then be able to do it truly with as close to 100% of families as we can so that things are not overlooked. And that's part of why our network has had such a focus on quality improvement and reliably doing important things, because all of these little things can have a big impact on the individuals that we serve. Were there any?
So we have we have a few questions. So one question is about whether or not there will be a follow-up presentation related to anxiety and depression, more specifically for the kids that are transitioning, out of the pediatric setting into more of an adult care setting. So we don't have something like that on the books right now for a future webinar, but I think it's definitely a great topic and one that we can, look into adding to the schedule.
It absolutely is, and thanks for bringing that up, because as we develop our webinar series, while we partly present on advances in research, the C in AARC is advances in care, and some of those topics come from our attendees at the webinars. So thanks for that recommendation, and we will follow through with that.
And another question kind of related to another possible comorbidity that wasn't discussed in detail, whether or not there's a higher rate of bipolar disorder that is seen for those with ASD.
That's another great question. As I mentioned, I focused on the medical conditions today rather than on the behavioral health conditions. Bipolar disorder is a condition that is, like every other condition in the Diagnostic and Statistical Manual, 5th edition, the DSM-5, all of those mental disorders are what we call behavioral disorders. They're based on a set of behavioral symptoms and not based on good, hard laboratory studies like so many medical problems. For example, x-rays showing pneumonia, or strep tests showing that your sore throat is caused by the streptococcus bug. When it comes to bipolar disorder, many of those symptoms of rapidly changing mood, extreme mood swings, mania, overactivity and agitation, and then going the other extreme, depression with withdrawal and sitting and not interacting, those can be seen as variations of typical autism behaviors, but they also could be bipolar. we don't have any laboratory tests or x-rays or anything to differentiate them. And so a lot of it comes back to one of the themes I've mentioned today. We need to be aware, we need to be questioning and thinking, could this be something else? Some people feel that bipolar disorder is being overdiagnosed in people with autism and that what they're seeing is just regular autism behaviors. Other people are 180 degrees opposite, thinking it's the other direction. I think putting together an AARC webinar looking at all of these might be a good topic for us to try to explore in the future. So I don't have a good answer for you, but I think that's a great topic that we do need to explore.
And just, we have about a minute left. There was a question about a listing of the journal articles that were mentioned in Dr. Coury's presentation. I can just say the articles that are specific to our work with the AARC ATN are on our website, asatn.org. There's a publication listing for all of our publications. And Dr. Coury, did you have any kind of thoughts on the other papers that were mentioned in your presentation?
Well, the other papers that are mentioned, for the most part, many of them are in journals that are open access. So whether you are associated with a university or if you are a family, you may be able to go to PubMed and look them up, and many of them are freely available. In addition, we routinely record these webinars. This will be recorded and posted, and so you'll be able to view this again, pause it so that you can get the specific reference information and then go look those up. But I encourage you to do so.
Great. So we are out of time for today's webinar, but I just wanted to remind everyone that a link to an evaluation will be sent to you via email, and you can complete that evaluation for CME credit. And then if you have any further questions that you would like to pose to Dr. Coury, or any questions about upcoming webinars or the webinar distribution list, then you can email me, Audrey Wolf. My email is on the screen. So thanks everyone for attending, and thanks Dr. Coury for presenting for us today.
Thank you, and thanks again everybody for tuning in, and I hope you enjoy the rest of your week. Bye now.
Bye.